Well, good afternoon and good morning to those that are on the West Coast. I wanted to greet everyone. My name is Derek Bailey. On behalf of the National Native Network, I would like to welcome you to today's National Native Network webinar titled Cultural Context of Indigenous Health Disparities. This technical assistance webinar is hosted by the National Native Network, which offers technical assistance and resources to reduce health disparities related to commercial tobacco abuse and cancer throughout Indian country. Your presenter today is Dr. Melissa Lewis, an assistant professor at the University of Minnesota Medical School, Duluth, in the Department of Bio-Behavioral Health and Population Sciences, the only medical school in the country with a mission of American Indian Health. She is also a research fellow at the Research for Indigenous Community Health Center in Duluth, Minnesota. Dr. Lewis received her PhD in medical family therapy and is a licensed marriage and family therapist and an American Association of Marriage and Family Therapy approved supervisor. She is an enrolled member of the Cherokee Nation, which informs her research and clinical values, goals, and interests. Clinically, she supervises medical and behavioral health students using an integrated care model and social justice focus. Her research interests span integrated care in both military and indigenous populations, examining the role of stress and trauma on cardiovascular disease in indigenous populations, and interventions aimed to empower indigenous families and communities by privileging indigenous knowledge and practices. By the end of today's webinar, participants will be able to, 1, identify pathways from early childhood that affect adult health outcomes for Native people, 2, identify and define indigenous-specific stressors that affect adult health outcomes for Native people, and 3rd, identify interventions that will reduce the incidence of metabolic disorder for Native people. Questions will be posted and answered during the last few minutes of the webinar. Please type any questions you have in the designated box on the GoToWebinar screen. Ladies and gentlemen, Dr. Melissa Lewis.
Nagata. Hello, everyone. Let me just make sure. Is my screen being shared? Okay, I think we've got it. Well, thank you very much, Derek, for that introduction. And thank you to the National Native Network for inviting me to present today. I also wanted to thank Robin for all of her help in organizing this presentation. So I'm going to talk a little bit about Indigenous health disparities today. As Derek mentioned, I'm an assistant professor at the University of Minnesota Medical School at the Duluth campus. And so what that means is I am in the initial stages of putting together my research interests, my research trajectory. And so what you're going to hear about today is a lot of the background that has been kind of put into the work that I'm starting right now on cardiovascular disease in Native people. So I asked a lot of questions and I did quite a bit of literature review, and so that's what I'm going to talk with you about today. So you should see some beautiful faces on the first page. These are Abenaki friends and relatives of my colleague, Dr. Erica Hartwell, and she's one of many people who has helped me put together some of the work that you'll see today, and I just wanted to recognize them here. So to start out, I wanted to give some brief definitions here of metabolic disorder and heart disease. So metabolic syndrome is a name for a group of risk factors that occur together and increase the risk of CVD, stroke, and type 2 diabetes, with the risk factors being large waistline or hip to waist ratio, high triglyceride, low HDL, high blood pressure, and high fasting blood sugar. CVD, or heart disease, is a broader term used to describe a range of diseases that affect your heart. It generally refers to conditions that narrow or block your blood vessels and that can lead to heart attack, chest pain, or stroke. But there are many other heart conditions, such as infections and those that affect your heart's muscle, valves, or beating rhythm, but they're all considered a form of heart disease. Oops. There are 7 main risk factors for CVD. We've covered a few of them already: high blood pressure, diabetes and prediabetes, obesity, smoking, lack of physical activity, unhealthy diet, and stress. For Native Americans in the United States, the mortality rate from cardiovascular disease is quite upsetting. It's about double the rate of non-Native people in the United States, with women being even more vulnerable. And you can take a look, depending on where you're at in the country today, and see, the darker the red, the higher the mortality rate of American Indians from CVD in that region. Michigan stands out quite a bit to me, as does South Dakota and the Dakotas. So for Native people, we have about 15 to 20% more atherosclerotic plaque, which is a significant CVD risk factor compared to non-Native people. In one study of a Midwest Indigenous population, 26% had high cholesterol, 28% had high blood pressure, 40% smoked cigarettes, 52% did not have regular physical activity, and 74% were overweight. And remember, these are the kind of American Heart Association standards that put together a risk factor for heart disease, and these rates are really off the charts. When we think about what causes heart disease, they usually go into 2 different categories: a genetic risk category and what many researchers call modifiable risk. And some examples of the genetic risks are heart defects, an infection, or family history of CVD. In that category of modifiable risk factors are physical activity, diet, smoking, and drinking and drug use. So just to give a bit of a broader picture about health disparities, not just metabolic disorder, there are 6 main reasons why there might be health disparities between different racial and ethnic minority groups. And they're listed here: limited access to appropriate health facilities, poor access to health insurance, insufficient federal funding, specifically IHS, quality of health care issues, disproportionate poverty and poor education, and a broader category of social and cultural factors. So in that brief review of heart disease and of heart disease with Indigenous people, these are areas that I'm very interested in, I started to become curious about a few different things, especially those fuzzy areas, like what is stress and what are those broad cultural factors. So for one, I was struck by, why do Indigenous people have more risk factors? Is it really that lifestyle alone, those modifiable risks alone? And to add on to that, and number 2, what is the relationship between the genetics and the modifiable risk factors? Are they related in any way? Third, I was interested in, what about the way that we live our lives, and how do we spend our time that affects our health? And in particular, for Indigenous people, I was curious about, how do our relationships with one another and with dominant society affect our health? And last, I mentioned already, what about stress? We don't know very much, but it's in all of the recommendations to reduce heart disease. So I'm going to share with you what I learned in trying to answer some of these questions. So in the relationship between stress and metabolic syndrome, we know that there is, excuse me, a genetic component. And the International Diabetes Federation said that there's a substantial component of metabolic disease risk that has a prenatal developmental basis. If you take a look at the diagram on the left, you'll see that for mothers who experience prenatal stress, they have changes in their metabolism, and physiology. Continuing stress leads to increased maternal cortisol, which is a stress biomarker, increased insulin of the mother, and increased blood pressure of the mother, which is then starting to affect the health of the unborn child. We'll explain this a little bit more. Okay, so in investigating genetics, the genetic component of metabolic disorders, we do know that there is a proportion of our genes that matters when we, for our risk for heart disease. However, the proportion, when we look at type 2 diabetes, for your predisposition is 5 to 10%. It's relatively small. And in addition to that, the genes that are associated with the increased likelihood of diabetes are as common in non-minority as minority people. Therefore, any theories that we had about the reason why Native people experience diabetes and cardiovascular disease at an increased rate, as it could be reflected through genetics, we don't really have that science to back that theory up. However, when we have looked at the research around epigenetics, and mind you, my background is in psychosocial health. I'm a licensed marriage and family therapist, so what I know about epigenetics is limited, so just have that in mind here. But we do know that the genetics that are a reaction to the environment, called epigenetics, do relate to diabetes and heart disease in a number of ways. So if someone is exposed to react to something in the environment, such as a highly stressful event, their genes for stress tolerance may be switched on or off. And some key components of that are really fascinating and in some ways problematic are that when these genes are switched on or off, they may not be reversible if it's in a key developmental stage of life. And in addition, they're heritable, which means that once they're turned on for one generation, they can be passed down to subsequent generations. So an example of stress and early life experiences come from a study about rat pups. So rat pups that were raised by nurturing mothers ended up having a gene which codes for stress hormone receptors that is turned on. Therefore, they grow up and they're more stress resilient. So when they are put into more stressful environments or situations, they physiologically don't react to it as much. So their heart rate or their blood pressure won't go up as much as compared to rat pups that are raised by neglectful mothers who are put in the exact same stressful situations, and their heart rates, for example, their stress hormones and their blood pressure will go up. And this kind of research is being found in humans now as well. Another important aspect of early life development and stress is low birth weight and preterm birth. So maternal stressful life events during the first trimester in particular increase the risk of preterm birth and low birth weight by an odds ratio of almost 2.5. So SGA and preterm are both strongly associated with the baby's later risk for chronic disease. That's why low birth weight and preterm births are so important. And here's just a table demonstrating some of those odds ratios, and we can look at the first and second trimesters here. So you'll see the odds ratio for stressful experiences in the first trimester is 2.4 times more likely to have low birth weight and preterm, which sets children up for an increased likelihood of chronic health diseases later in life. It actually increases a little bit in the second trimester at a rate of 2.86 times more likely, and there isn't any significant relationships in the third trimester. And when I learned about this information, what I thought about was our Native children, young women as well, because we know that 1 in 3 Native women experience sexual violence, which is 2.5 times more likely than non-Native populations. in Minnesota, where I live, in Hennepin County in Minneapolis, Native American women, who are only 2.2% of the population, represent almost 25% of the people on probation for prostitution, which through a really wonderful piece of research, the Garden of Truth, I can add that to our link of resources, found that the majority of those who are on probation for prostitution are really and truly victims of human trafficking. There's a wonderful website with more information on that, humantraffickingsearch.net. So overall, learning about this made me very concerned about the health of our children, and as they grow up, the likelihood of chronic health disease that they're going to be suffering from. All of this research falls under the title of Fetal Programming of Health, and so if you're interested in learning more, you can research fetal programming of health or of type 2 diabetes or of cardiovascular disease. But researchers have said that it is important to understand that the story is not about birth weight, but about fetal programming, and that intergenerational prevention of type 2 diabetes will need to target maternal health. Prevention of fetal programming of diabetes, and I would add metabolic disorders, will need to concentrate on the health of young girls. Now this stuck out to me quite a bit because when we think about diabetes and prediabetes, we might be getting folks as early as 20 and 30, and for heart disease, we're diagnosing people in their 40s and their 50s. But the research is showing that these are really symptoms of problems that start in our childhood or even more during these kind of the fetal origin period, which made me think, gosh, we're really looking at metabolic disorders a little bit backwards, and we need to go more to the root, to these final symptoms that we're seeing 20, 30, 40, 50 years later. So the other aspect of heart disease that I want to talk about is the relationship between stress and heart disease. And in a meta-analysis, so in a compilation of research studies about stress in the workplace, they found that CVD was 50% or 50% more likely for those reporting work-related stress. In another study, they found that stress is more predictive of heart disease than cholesterol, which historically has been deemed one of the most critical predictors of heart disease. And stress does two things. It increases the likelihood of those Framingham CVD risk factors, which is this kind of a top-tier system that can predict the likelihood of CVD. But it not only increases the likelihood of those things like cholesterol, smoking, and diabetes, but in itself, it's an independent risk factor, making it a very powerful CVD contributor. There's a number of other linkages from stress to CVD, from stress hormones, vasoconstriction, atrial fibrillation, myocardial infarction, abdominal fat deposits, worsening of congestive heart failure, and increasing the likelihood of broken heart syndrome. So this leads me to the next step, which was, it is clear that the environment has a relationship to our health, and it starts very early on, and it can be intergenerational in nature. So what are the specific stressors that Native people experience, and how do they relate to heart disease? The first one I was interested in taking a look at was historical loss. We know that there is a relationship between historical factors and our current health and well-being. Many of you have maybe seen this little video, but I'll share it with you now as well. Oops. So historical loss is not simply the loss of land. It's the cumulative emotional and psychological wounding over the lifespan and across generations, emanating from massive group trauma experiences. When you hear about historical loss and trauma in research, you're probably hearing about the historical loss and associated symptoms scale, in which researchers ask participants how often do they have thoughts about loss around land, language, spirituality, the boarding school and removal era, broken treaties, and early deaths in their own family. One of my colleagues did research with doing qualitative interviews asking participants who have experienced historical loss about their experiences. This is Dr. Melissa Walls who did this research, and one of her participants said that the problems we have are just symptoms of our main problems. I think like we try to solve alcohol problems, sniffing, and the fighting families, you know, those are just symptoms to me. Like residential schools, for example. That's where we pretty well lost everything. So intergenerational historical loss and trauma emanated usually from, when we talk about it, people usually talk about the era starting at around the 1800s, when children were forcibly removed from homes. They were not allowed to speak their native language. There were federal policies prohibiting religious tradition, and U.S. government backed and supported forced sterilization of Native women. So there is lots of cultural practices and oral history that has had a devastating effect over generations. And I think my colleague, Dr. Laura Myra, who put this figure together, did it quite well. Up top, you'll see the era of assimilation or genocidal policies. Underneath that, you'll see the age range, the time frame in which those eras took place. And she mapped it onto our familial generations. And what's so striking to me about this diagram is that historical loss sometimes is thought of as one thing that has happened at one point in time. And this shows that it clearly wasn't. It would be a very different, I think, experience if we looked at the great-grandparent who had been through boarding school and all of the other mandated policies did not occur. So you had a great-grandparent who experienced loss and trauma, and over generations we know usually people's psychological health improves. But what we're seeing here is that at every single generation, not only are they a product or a child of a parent who experienced significant traumatic loss, but they're experiencing loss in a new and profound way. So there's three things that I've seen that really seem to encompass what it means to be colonized. Diminished autonomy. So, for example, the U.S. government and Congress can forcibly interrupt tribal governments. Many tribes are named by Europeans, so they are not what we would call ourselves. I know there's a wonderful map out there by, I think, a Cherokee that has a map of the United States in each tribe's language. I'd love to have that map someday. Another example is diminished identity. U.S. government kind of created one race or so-called race by combining these 566 or more distinct nations into one group. And then success has been measured by how assimilated these groups and individuals have been. Also a diminished self-worth. History is not taught in schools, and when it is taught, you'll see that leaders who maybe have been folks who have passed policies or been in charge of actions that have been really damaging to Native people are heroes in these history books. In addition, Indigenous people exist in this dominant discourse as caricatures of a past era and not represented today. I'd like to also share with you some of the research findings around historical loss and trauma. At the individual level, historical loss has been associated with feelings of anger, depression, suicidal ideation, anxiety, interpartner violence, substance use and abuse, negative self-image as well. And these thoughts about historical loss are pretty prevalent. Over half of adolescents report daily thoughts about historical loss, and around a third of adults report more than one thoughts about historical loss. This is also a family event, as well as a cultural and a community event by nature and by definition. And some of the research looking at how historical loss has affected families over time. Dr. Melissa Walls did a project looking at 3 generations and found that historical loss was related to parenting techniques, substance use, and depression over these generations. Dr. Laurel Myra has found the relationship between historical loss and substance use patterns over 2 generations. And what was very shocking to me is, again, we usually think about historical loss as something that happened once in time, and that it's something that over time our wounds will heal. But Dr. Les Whitbeck found that in this study, adolescent report of historical loss and trauma was actually increased compared to their parent or caregiver. Historical loss and trauma, I think, also occurs at a societal level. There are inequalities that happen for Native people in terms of the health of their living environments, learning environments, and education, and healthcare and housing, for example. You'll see an image on the left of a family asking for a mold-free house because their child keeps getting ill. On the right, you'll see a picture of a group of Canadian youth at Attawapiskat asking for the Canadian government to give them a new school. You all might be familiar with this movement. Shannon Kustation, an Attawapiskat tribal youth, started a movement to have a new school built because their current school had been contaminated from a diesel spill, and students were going to school at makeshift portables and, up to negative 40-degree weather. And Shannon started the largest child rights movement in the history of Canada and called upon the Canadian government to properly fund the First Nation Aboriginal school system in Canada. And unfortunately, she didn't have a chance to see the school being built because as she graduated into junior high and high school, she had to attend a school that was 600 kilometers away. And going to school one morning, she was killed in a car accident. There are a number of things I've brought up here, but I just wanted to share that these are things that happen for Native people across the United States, Canada, and the world, and they certainly affect health in a number of profound ways. I did hear that Shannon Kustation is now a hero in a comic book, but I haven't had a chance to look at that comic book yet. All right, I'd like to move on to adverse childhood experiences and health outcomes. For Native children, the out-of-home placement rate is incomprehensible to me. It's twice the rate of the general population, and Indigenous children are placed out of home at rates 13 times higher than a white child. They're 20% more likely to be placed outside the home post-adjudication compared to a non-Native child. And Indigenous children represent 2.6% of the foster care population, yet they only encompass 1.2% of the general child population. And if you take a look at the diagram on the left, you will see the rates for children in out-of-home care per 1,000. And you can see the different racial and ethnic groups from Asian Pacific Islanders, white, Hispanic, 2 or more races, African American and Black, and at the very top, at almost double the rate of all of the groups, is American Indian children. And with the history of the policies between the federal government and the sovereign tribal nations around children displacement of the homes. This makes a lot of sense that we're seeing these rates. However, it's still shocking that they're so incredibly high. So the state that I'm currently living in Minnesota, has the largest rate of Native American children being placed out of the home. And it's the second highest is Washington, the state of Washington, and their disproportionality index is 4.1. Oh no, excuse me, it's 5. In Minnesota, it's 12. So it's almost double the second highest rate. It is truly, absurd to me and a call for a state of emergency because it is so high. And you can think about the map that I showed earlier in regards to mortality from heart disease and try to remember and map it onto this, and you'll see those Michigan, Wisconsin, Minnesota, South Dakota, some of the same places you'll see in this map as well. Again, many of you might be already familiar with adverse childhood experiences. It was a very large study started out of Kaiser Permanente, and they found, actually looking at a study about weight loss, that those experienced those 7 items on the left of the screen under the childhood, those adults were less likely to lose weight. That's how some of this ACE study research started, but now it's really expanded. So adverse childhood experiences are emotional, physical, or sexual abuse of a child, usually from the ages 0 to 18. A child who has experienced substance abuse in their home, their mother has experienced violence in the home, someone in the family or in the home has been incarcerated, and parental divorce. And the way this measure usually works is you just count them up 1 through 7. Sometimes measures have more than that. So if you have experienced a significant amount of ACEs, adverse childhood experiences in childhood, you're more likely to abuse alcohol, tobacco, or drugs during adolescence. You're more likely to have a premature sexual intercourse and more likely to have a suicide attempt. In addition, as we move through time, as adulthood, if you have a significant amount of adverse childhood experiences, you're more likely to experience alcoholism, smoking of tobacco, drug use, and depression. You're also more likely to have an unintended pregnancy, a sexually transmitted infection. You're more likely to be obese, have liver disease, and even cardiovascular disease. So for Indigenous people in particular, this study looked at the comparison of exposure of ACEs for Native and non-Native people. To me, it was pretty shocking. On the left, you'll see physical, sexual, and emotional abuse as along with household alcohol use. For every category, Indigenous children experience more of these events. And in much of the literature, we found that there's a critical number of ACEs that leads to mental and physical health outcomes, negative mental and physical health outcomes in adulthood. The cutoff is usually around 3 or 4, sometimes 5. And so if you have 4 or more ACEs, it significantly increases your likelihood for those negative health outcomes as an adult. And if you look at the bottom of the screen here, Indigenous people experience ACEs they're 5 times more likely than non-Native people to have that critical threshold. So this is very important. Adverse childhood experiences are also linked to worsening mother-child relationships, reduced cognitive development for children, and the risk for obesity is 1.5 times more likely, diabetes 1.5 times more likely, heart disease 3 times more likely, and cancer 1.2 times more likely. So again, interventions for American Indian children, and if we fold in the recommendations from earlier, American Indian girls and women in particular, and families are the priority to reducing these adult health outcomes. There's a wonderful study that you can take a look at the references at the bottom that looked at adverse childhood experiences and epigenetics. And they found that assaultive trauma is linked to post-traumatic stress disorder more than any other kind of trauma. So you're more likely to get PTSD of all the different adverse childhood experiences if you've experienced an assault as a child. Adverse childhood experiences are most linked to epigenetic changes due to the child abuse, both physical, emotional, and sexual. Direct physical abuse and observing abuse of mother is associated with greater methylation, which is the scientific process of epigenetics. Victims of child abuse or neglect are related to a reduction to an inflammatory regulation gene. So those who are victims of child abuse or neglect are less likely to be able to have a gene that regulates the inflammation that usually results from stress. Right, I'm going to kind of shift to another, what I would call an indigenous specific stressor, and that would be the experiences of racism, discrimination, and oppression, and specifically looking more at the institutional and societal levels. Many of you have probably heard many of these terms here on the right before. I will just give some brief definitions. Racism are actions, practices, and beliefs that consider different races to be ranked as inherently superior or inferior to one another. Discrimination is prejudicial treatment of an individual based on their group membership. Colorblind racism is an idea that race is no longer an issue in this country and that there are non-racial explanations for the state of inequality in the United States. Historical trauma, there are symbols and reminders in our daily lives. So the thoughts that we've been doing research on, they may be related to some of the things in our environment, such as seeing a $20 bill with Andrew Jackson on them, or President Lincoln, which for many Native people or for specific Native tribes represent genocidal experiences or mass hangings. So I would call these historical trauma symbols or reminders. In addition, cultural appropriation is the adoption of specific elements of one culture by a different cultural group, usually done without the permission or consultation of the original group, thereby changing the meaning of the original item altogether. So I put a few pictures up here that demonstrate some of those terms that I just explained to the right. So what is the relationship between discrimination and heart disease? Well, there's another wonderful study that I have listed here if you want to check it out that demonstrated that discrimination does have a significant relationship with health outcomes. So 90% of those who experience discrimination in their population experience negative mental health outcomes, including depression, clinical psychiatric distress, and worsening well-being. 99% of the population in their study that experienced discrimination also experienced physical health outcomes or physical health risks. Third, increased participation in unhealthy behaviors and decreased participation in healthy behaviors occurred for 89% of the population that experienced discrimination. The authors also found that there were causal pathways for heightened psychological and physiological stress responses, such as heart rate increasing, blood pressure increasing, etc. But there was one ray of hope in this study, and that was that social support significantly buffers these effects. And when I think about Native families and communities and tribes, I think about how important and how wonderful these groups support each other and the skills that they already have. So despite all of the negative information that I've shared with you today, I know that tribal people have students at University of Minnesota is doing a wonderful study about positive mental health and is finding that Native people have more positive mental health than other groups. And Native people have so many strengths. So this makes me feel okay at the end of the day compared to all the other information I've already shared with you. So what are ways to intervene? One of the ways I think is privileging those indigenous ways of being that I started to allude to, and the privileging indigenous knowledge and life ways. In one of the, at the bottom, there's a Center on the Developing Child at Harvard. It's a wonderful website and resource that is accompanying this lecture that is wonderful to take a look at. The center said that we know that sound maternal and fetal nutrition combined with positive social emotional support of children through their family and community environments will reduce the likelihood of negative epigenetic modifications that increase the risk of later physical and mental health impairments. And I think that sums it up really well, and there's ways that we can indigenize that. This quote by Went and Gone might be a key to that. They said to uncover the detrimental effects of European American colonialism and to assist historically colonized groups with preserving and reclaiming their distinctive cultural legacies, strengths, and institutions is the key to this. So this is an image that I am sure is very familiar to many of you at the Carlisle Indian School, and I want to reflect on this image and counter it with this next image, which is the inaugural, if I understand correctly, Soaring Eagles Powwow Dance Workshop that started in 2008. That was sponsored by, if you look at the top, the California Indian Education. In other words, the BIE or the BIA, the same group that was responsible for boarding schools not too long ago. So this is a kind of another exciting glimpse into a way that we can indigenize early childhood programs. Some other examples are putting resources into cultural revitalization through things such as language immersion schools, being able to exercise our treaty rights and passing them on to the next generation, teaching the skills of foraging, fishing, and hunting, for example. Also adding cultural schooling to school or after-school programs, or many other variations of schooling. Some examples are beading, moccasin making, and bow making, which you'll see a picture of a basket making on the right, and on the left you'll see a student who's learning to use the Cherokee syllabary on their MacBook there. So one of the interventions that's been shown to be evidence-based is early life or prenatal home visiting. And it's improved the life trajectories of at-risk women and children. And the positive effects of these in-home early childhood intervention has now been shown up to age 9 years old. So children who participate in these programs at 9 years of age are less likely to be obese compared to the populations who have not gone through these programs. In this study, the researchers said that if home visiting were a medication, it would be malpractice not to provide it because it is so effective and cost-effective, which I'll show you in a moment. There are also many programs that are available, I believe around 19, in the resource packet that you can get with this presentation. There is a link to the site, Tribal Maternal, Infant, and Early Childhood Home Visiting Program. And there are 9 home visiting models that have found evidence of effectiveness. So there are many different models that tribes can use. And you can see, if you go to that site, which tribes have already implemented the home visiting programs. Another example that's very similar is a nurse-family partnership, and it's another evidence-based program. Registered nurses are partnered with mothers, first-time mothers living in poverty, and they can start early in the pregnancy and go through the child's second birthday with the goals to improve prenatal care, the quality of parenting, and the quality of life prospects. And the results of these interventions are really astounding. You can see in the middle there's a comparison group who did not have the nurse-family partnership, and on the right you do see the participants. As far as language and achievement, participants had increased language skills and academic skills, decreased days hospitalized. For the mother, the months between births increased, and the months receiving welfare assistance and food stamps also decreased, which shows that this is fairly cost-effective. And in fact, it's very cost-effective. For every $7 that is put in to one of these early childhood programs, $1 is invested. So, for instance, $7 in average is returned to the public in the areas of crime costs, reduction of costs, special education, welfare savings, and increased income taxes. So there are 3 different programs. Many of these are programs that started in New York with low-income black families, but you can see the average dollar amount is about $7 for every dollar invested, which is phenomenal. And you can see the break-even point, which, of course, each of these 3 different kinds of programs just went above and beyond. So overall, these interventions, whether it be the early childhood interventions, the nurse-family partnership, they have to have some core components. They have to be integrated. It can't be a stitched-together list of disjointed services. So if there's a service where nurses are educating new moms, and there's also linkages to primary care location and maybe also substance use services, they have to be linked together. They can't be difficult to access. There has to be coordinated care, and in addition, there has to be one consistent staff person at the center for each family. So a family can contact one person, so that really gets rid of the barriers for families. The programs have to be carrots, not sticks, for participating in programs and interventions. So for example, some of the programs paid pregnant women for clean drug screens. They paid them for going to their prenatal appointments, and they paid for their parenting classes. And they did so because they knew the cost offset for the child's health and the mother's health is going to significantly overshadow any of these costs that are given up front. One example that I like to share at the Fond du Lac Ojibwe Reservation, which is the closest reservation to Duluth, Minnesota, and Cloquet, is that after the mothers complete the intervention, if they complete it, they receive the moccasins that you see here on the left. And I remember talking with the artist, Miss Sarah Howes, and she said that, you know, reluctant mothers or busy mothers who find it hard to go through several months of these programs will go through it because they're so excited to get a pair of moccasins for their newborns, and they are very beautiful. And so obviously culturally tailoring the carrots is critical. In addition, the interventions have to be strengths-based and relationship-based. We've talked a lot, or the research has found that it's so important to consider young women and mothers in the larger picture. Oh, apologize here. In the larger picture of preventing chronic health disease in later life, but women are within a family and within relationships and within tribes and those have to be accounted for in these interventions as well. Another example or kind of important part of these interventions is that all pregnant women should be a part of these interventions, and their only option is to opt out instead of opting in. That way you capture more people, and more pregnant women have the opportunity to participate. And with that, I would like to thank you all again for your time. I know it was a lot of information, and I believe we have time right now for some questions.
Well, first I want to thank you, Dr. Lewis, for a great presentation. And you're right, it was a lot of information that you presented and shared with us. We are grateful for that. If anyone has any questions for Dr. Lewis, we ask you please type those in the question box that's on the screen. So at this time, are there any questions for Dr. Lewis? We'll just give for a few more minutes or a moment here for any questions. You know, again, we are very thankful on Dr. Lewis for presenting this afternoon. And for those that are online and attended, we will email all attendees a copy of Dr. Lewis's presentation and also a link to a brief evaluation for today's webinar. We do thank you all for attending the National Native Network Technical Assistance webinar. But I still, before signing off, just like to take a moment just for any further questions. If not, again, we will be emailing all attendees a copy. And we thank you again, Dr. Lewis, for your presentation, and we wish everyone a good day. Thank you.
Thank you, Derek.